everyone. Thank you for joining us. We start off real quick with an introduction. Dr. Netscher is an academician with a lifelong career at Baylor College of Medicine in Houston, Texas. He has served as professor in the Department of Orthopedic Surgery and the Division of Plastic Surgery since 2006, and is a program director for the Hand Surgery Fellowship for more than 20 years. His specialty involves congenital anomalies, trauma, arthritis, contractures, oncology, vascular and peripheral nerve problems. Additional, Dr. Netscher has served as both a director of both the American Board of Surgery and the American Board of Plastic Surgery, as well as on the Conjoint Hand Surgery Board. Dr. Netscher received his medical degree from the University of Witwatersrand Medical School in Johannesburg, South Africa, and clinical fellowship training in hand surgery at the Christine M. Kleinhardt Institute for Hand and Microsurgery. Additionally, he completed a general surgery and internal medicine internship at Johannesburg General Hospital and a general surgery residency at the University of Louisville, followed by plastic surgery residency at Baylor College of Medicine. He's also our incoming president-elect. So without further ado, Dr. Netscher, if you'd share your screen out, we'll get started.
How does that seem to you? Is that you see?
Yeah, that looks good. Looks good. Thank you.
And then it advances nicely. I think we're ready to go. Randy Glick, thank you so much for the introduction and welcome to part 2 for sports medicine in the hand and upper extremity. And thank you so much for joining in with us. Our topics are going to be fractures and dislocations, metacarpals, phalanges, hook of hamate, and then the MP joint and PIP joint dislocations. Those fractures, the metacarpal and phalanges and the MP and PIP joints, are probably amongst the most common sports-related injuries, as you can imagine, especially with the ball sports. Hook of hamate is relatively uncommon, but can be a puzzle in the diagnosis and treatment. Other common injuries that occur on the sports field are the closed tendon injuries. So the mallet, a deformity at the terminal end of the finger, boutonniere, and that can sometimes cause a little bit of puzzlement as to the mechanics and the pathomechanics of the boutonniere deformity. The jersey finger and the flexor tendon ruptures, and what's called a sagittal band rupture. And then finally, we're going to address some of the tendinopathies that we did not address in part 1, particularly de Quervain and intersection, which are overuse syndromes, and the exertional extensive tendinitis. So we're going to jump right in with metacarpal fractures, and these occur particularly with the contact sports, football, lacrosse. We may have metacarpal head fractures, and always be concerned if there's an open injury to the skin that it might be a fight bite. And when we say fight bite, it doesn't necessarily mean maliciousness, but someone may have just impacted the hand against someone's face, and in the process got a tooth mark or a so-called fight bite, and that needs to be addressed urgently with irrigation and debridement. Then the metacarpal neck fractures, the classical boxer's fractures that occur more commonly at the ring and the little fingers. Examination is particularly important, and even more important than the imaging, and especially to look for displacement. And the most important displacement is the rotational alignment, because that we cannot remodel. Angular displacement, volar to dorsal or radial to ulnar, can often remodel, and I'm going to demonstrate this to you as well. The X-ray imaging is important, but MRI and CT is hardly ever required for metacarpal or phalangeal fractures. Looking at rotational deformity, it's important to flex the fingers. And we've drawn out here how the fingers all point to the tip of the scaphoid, to the scaphoid tubercle, and the nails are lined up accordingly. And as an example, we can see here in a cartoon fashion, we can get fracture displacement volar to dorsal, side to side, but it's this spiral, this rotational deformity that we really have to watch out for. And here you can see the fingers are flexed and the index finger is obviously out of alignment, and it's that spiral deformity that's always going to need correction. And the deformities come about as a result of the unequal pull of the tendons working across the fracture line. So this is a real-life example where you can see the patient has spiral fractures of the metacarpal shafts of both the little and the ring fingers. And clearly you can see these two line up and will point down to the scaphoid tuberosity. These two will not. That doesn't necessarily mean that this needs an open reduction, but you might be able to do a closed reduction and then percutaneous pinning. Now all of a sudden the fingers are nicely lined up and pointing down towards the scaphoid tubercle. So I use this case as an example for what you need to look out for in the clinical examination. We're going to start at metacarpal neck fractures, and that's the so-called boxer's fracture that will occur just at the neck of the metacarpal. And these can be a little difficult to reduce because we've got no purchase. We can't grab a hold of the distal portion, but you can acutely flex the finger, and you might assist yourself by giving a metacarpal digital block so that it becomes painless. And then you can use that as a fulcrum and leverage to then straighten out the displaced fracture. There's a certain amount of latitude with how much displacement we can tolerate. And at the little finger, even as much as 40 degrees of angulation will be tolerated, especially at the little finger, because the little finger is much more mobile than the index or ring or middle finger. As a rule, even if I don't think I'm going to need to do an operative reduction, the best time to improve the position is in the emergency room when it's acutely, and I'll give a digital block just so that I can comfortably put the patient in a post-operative splint. And then thereafter, I will, once I've done the digital block, I'll do a manipulation to get the finger as lined up as best I can. And then casting in an intrinsic plus position, as we see here. You don't want to cast them in this position because that's not very safe. This maneuver is used only in order as to provide leverage to accomplish the closed reduction. Metacarpal head fractures, as I've said, if there's an open skin injury, suspect the possibility of a so-called fight bite that may or may not be maliciously obtained. If there's a metacarpal head fracture with significant articular involvement, then those are going to need operative intervention. The metacarpal neck fractures we've just talked about. Absolute surgical indications for metacarpal neck fractures are if there's a rotational malalignment, and this applies to all of our fractures, or if there's an open fracture that needs to be washed out. And occasionally, just because there's so much shortening, we get so-called pseudo-clawing. And that's because the extensor mechanism is now redundant, and so you can't extend the finger fully. And so then you get that sort of claw position, almost like an ulnar claw, and you may need to reestablish length of the metacarpal. There are various ways of intervening for surgery for metacarpal fractures. And you can use pins, and this shows the approach to place an intramedullary screw that we'll use. This is a cadaver dissection, so it's accentuated to show the exposure, but we can actually do that percutaneously through a buttonhole incision and place then a percutaneous longitudinal screw if we choose to fix the metacarpal fracture. Most can be treated non-operatively. However, in this case where you see you've got someone with multiple fractures, one would obviously want to treat them operatively. There are a host of different types of fixations. And generally, we try and get the most sturdy that's possible, and that usually implies doing an intramedullary fixation, and that allows us to get earlier motion, and it also allows us to place the screw through a very small incision rather than having to open extensively, as you would see might be if you've got multiple plates and screws. So most of these patients, I've said, can be treated non-operatively. And surprisingly, you look at this and you'll say, wow, that's really displaced, that's shortened, that's a metacarpal shaft or neck fracture. But there was no rotational malalignment. And so this patient was treated solely with buddy taping. And you can see here in this, there's a video here. And this is the final functional outcome. And that's after less than a month from the time of her injury. And there's no way that with operative intervention, we could get that degree of function back so quickly without the adverse effects of scarring and potential stiffness. So while I've shown many open fracture techniques, I'm trying to isolate those indications that need open reduction, but most of these can be treated non-operatively. So returning to sports, well, it depends partly on the sort of fixation that we've done. It also depends on what type of sport they're going back to. A football player who's a blocker can put a huge, big monster cast on the hand and give it total protection, and that's legal for their particular sport that they play. But usually it's going to take about 6 weeks for bone to consolidate strong enough to be able to return to sports. We'd like to get pins out sooner than that so that they can start moving, but it's a protective motion and maybe still protected in a splint, and definitely not returning to full contact sports for 6 weeks or a little bit longer. The advantage of the intermedullary screws, as we said, is that we can get a little earlier motion. We can get patients moving earlier, but it still takes the 6 weeks for the bone to consolidate, no matter how we've done the fixation. So MP joint dislocations. These are relatively rare, and a dislocation is described by the position that the distal fragment takes. So if it's distally dislocated dorsally, then it's a dorsal dislocation. And those are the most common when you land on a hyperextended, stretched hand. 50% of these fractures are going to be associated with of these dislocations are going to be associated with a fracture, and so may require operative intervention. As we've said, these are dorsal dislocations. So here you can see it's very important to get all 3 views, AP, lateral, and oblique, because the AP view can look surprisingly normal. And it's only on the oblique and lateral views that you really see the dislocation. And you can see then the dorsal dislocation. Most of these will respond to closed reduction and then protective splinting and then allowing early motion. When you reduce it, if I show you my cursor here, you want to use your finger and just displace that, apply pressure, and push it over the ridge and back into location. You don't want to apply traction on it, because what's going to happen is that volar plate is disrupted, and it will, if you apply vigorous traction, that volar plate is going to get sucked into the joint and then obstruct your attempt to reduce the dislocation. Likewise, the head of the metacarpal can get in a noose between the flexor tendons, and the harder you pull, the tighter that noose is going to be pulled, and you won't be able to reduce the dislocation. And so that's why simply applying pressure dorsally and gradually pushing it over the mountain and back into position is the way to reduce it, rather than tugging and pulling on it, which applies then longitudinal traction. And then we may want to, when we splint them, we may want to prevent them from going into hyperextension for a couple of weeks, but at least allow them flexion in a forward direction. Occasionally, we may need to do operative management if we can't reduce the dislocation, and we'll either go dorsal or volar, dependent on surgeon preference. And we'll identify the reason for the soft tissue that may be interposed in preventing the reduction. It's very important, while we want to stop them going into hyperextension, to allow early flexion and early rehabilitation to avoid stiffness and post-traumatic stiffness. So phalangeal fractures we're now going to go on to. And this is a broad topic, but we're going to touch on the fractures as they are important to the sports medicine physician. And intra-articular fractures, of course, are important, and those are going to need to be operated very often, because you've got an articular surface. The phalanges are supported, as we'll show in a moment, by various skeletal columns and soft tissues, but very often, in association with a fracture, there's also a dislocation, a fracture dislocation. The larger the fracture fragment, the more unstable the dislocation is going to be. And you can see here is a very small fracture fragment, and so that joint is totally stable. A clue to the instability is the fact that you see this V sign. So instead of the joint being congruous, as you see here, there's a V sign here, and that shows that that joint is starting to dislocate due to this fracture fragment. So fracture dislocations are quite common and often unstable. Non-operative management, such as buddy taping, operative management for displaced fractures, malrotations, and for PIP fracture dislocations. And then return to sports, again, is going to depend on the fracture type, the fracture pattern, and also the position and the type of sport that they play. You can see that treatment of fractures, again, can be done by pinning, that as is commonly done, or by intramedullary screw fixation. And here you can see an intramedullary screw fixation, and this can be done through relatively small incisions, almost minimally invasive, placed percutaneously. Return to sports. Once the pins are removed, we can still provide protection by buddy taping, as seen here, and then gradually get them back to sports again, depending on the type of sport they play. Proximal interphalangeal joint injuries are extremely common, and these are the so-called jammed fingers. Timely diagnosis is important, and it's very important to keep them moving. Otherwise, they get stiff. They may not be able to return to sport, but certainly kept moving. They're particularly high prevalence in the ball sports and the catching sports. And this is an interesting comment that was made, that half of hand injuries involve the fingers in the national NFL. Wide receivers, defenses, backs were the most likely to, excuse me, to sustain finger injuries, most of which involved PIP joint dislocations.
Dr. Netscher,
Yeah,
can you please show us how to reduce? Was a question.
sure. Let me, for a PIP dislocation, most of them are dorsal. Actually, I'm going to come to that in a minute, Randy, and then I'll endorse that. And so,
Thank you.
so the bony stability comes from the lateral columns and the dorsal lips, and I'm going to show you that in a cartoon, but also the ligamentous stability of the volar plate. So the lateral columns of the proximal phalanx, and when you look at the lateral X-ray, these volar and dorsal lips are important, because if those are gone, then you have unequal pull of the extensor and the flexor tendons, and those are going to become unstable. So we have the collateral ligaments, the proper and the accessory collateral ligaments in the volar plate, and those provide the soft tissue support for the PIP joint now. So here is the most common dorsal dislocation. So let me see myself. So here I am. So here's my finger, and the PIP joint is dorsally dislocated. You'll accentuate going backwards, and then here you can apply traction, and then you'll apply traction and then go into a flexed position and bring it forwards. And in fact, you'll see the athletes, the basketball players, do this on themselves in the middle of the game. They'll just pull on it, bend it backwards, accentuate the deformity, apply traction, and pull down. So a PIP joint you'll apply traction to. With an MP joint dislocation, you don't want to apply traction to, because you'll just tighten up the ligaments. And there, if it's the MP joint, you'll apply a dorsal pressure on the MP joint and relocate that proximal phalanx by just pushing it back over the heel, if that makes sense. So there's a subtle difference between dealing with a dorsal dislocation of a PIP joint and an MP joint. Now, if you see this on a lateral X-ray, you can see there's the distal portion is kind of rotated, and the head of the proximal phalanx is sitting off. And what's happened here is that the head of the proximal phalanx has buttonholed through the extensor mechanism. And this is what's happened. So unlike the straight dorsal dislocation that we were talking about when I showed you how to reduce it, this dislocation, the harder you pull, the tighter the noose is going to become. So if you've got a complex dislocation like this, that may be irreducible. And if you have one or two attempts to trying to reduce it and it just doesn't come, well, then that's going to need operative intervention. And in fact, this patient, the way you'll reduce it is by putting the finger into flexion at the PIP joint. That'll relax this band to get out of the way, and then you'll be able to bend the finger into flexion. So if you've got a dorsal dislocation of the PIP joint, which is the most common, you'll actually accentuate the deformity going dorsally, apply traction, and then pull it into flexion. This particular dislocation at the PIP joint, which looks a little differently, you'll actually want to flex it and then try and put it to relocate it. If you can't relocate it, then it goes to the operating room. So this shows the importance of the collateral ligaments if you've got a fracture dislocation. So in other words, the piece of the proximal phalanx is broken off and it's dislocated out of joint because the extensor tendon is pulling it dorsally, pulling it out of the way. The bigger the piece, the more attachment there is of the ligaments to that piece. So then there's nothing that's going to hold the main bone back in place. That's going to become evident in a minute. So if we've got a fracture of the volar lip that involves up to 30%, it's probably going to be stable. If it gets greater than that, and certainly beyond 50%, it's almost going to be unstable. So these are our danger zones. As we showed, a less than 30% fracture of the base of the proximal phalanx is going to be stable. Anything more than that has the potential for instability, because as this piece gets bigger and bigger, so more and more of the collateral ligaments are attached to that piece, and this remaining portion is unconstrained and then is going to dislocate dorsally. So when we come to reducing these fracture dislocations, so this is different from the pure dislocation. We now have a fracture dislocation. You may find as you go into progressive extension, it wants to pop out of joint. So we'll use these extension blocking splints, which are simple kissing splints, or we can do it like this, so that we enable flexion, but we block to the point of extension where that joint wants to pop out of location. So we're continuing to keep mobility, but preventing the patient from getting into full extension. If it's just totally unstable, well, then they're going to need operative intervention. So this shows from a paper that I wrote, the interaction of the kissing splints to block going into hyperextension. You may do a similar thing with a Kirschner wire, with a K wire that's blocking it and stopping you from, it's a stopper preventing you to go into full extension until this fracture fragment is healed. And you can see that's just right on the borderline, about 30%. And when you ranged that finger, as you got into further and further extension, so it would pop out of joint. So we stop it at that point, and we put a rubber stop in there, a metal stop in there, and then they still are enabled to do flexion, but not achieving full extension until the fracture is healed. And then if it's totally disrupted, we do dynamic splinting and dynamic fixation, but we keep the joint going. So this is now for the operative intervention, where we've got a totally unstable PIP, fracture dislocation. So it's a fracture combined with the dislocation. And then when they return to sports, there's beautiful little hinge splints that the therapists can make for us. So we keep it moving. And the key with PIP joints is to keep them moving, but in a protected manner. If they have a very robust type of sport that they want to return to, well, you just immobilize the whole finger. And then they can't hurt it, at least while they're playing that particular sport. So we can get them back to sport earlier, depending on how rigidly we can immobilize them and dependent on what type of sport they're playing. And subsequent later protection with a simple prefabricated figure of 8 splint. So joint stability is critical. We want to get early motion as soon as possible, and certainly beyond 3 or 4 weeks, we've got to get them moving. Otherwise, they're going to be very stiff. And a finger that can't make a fully clenched fist is a very disabling hand. So hook of hamate fractures we're going to talk about. These are relatively uncommon, but can be puzzling in the diagnosis. And it's usually when there's an impact at the heel of the hand, as in a turf shot when playing golf and you hit the ground, or a tennis ball. And oftentimes, though, there's an unclear history, but there's pain and tenderness right over the hook of the hamate, which is at the hypothenar area, just right about where my finger is, right there. And you may have referred pain to the dorsum of the hand. There's a very important physical examination finding that I'm going to show you in a minute. But you can also get confused with your x-rays, because the hook of the hamate is superimposed on the other bones, and so it may be hard to identify. But there may also be a separate ossification center that looks like a fracture, but really isn't a fracture. So there's pain over the hypothenar region of the palm. And then I'm going to show you this hook test in a minute. And there occasionally may be nerve irritation, especially the ulnar nerve. Imaging x-rays can be really hard to identify, and we may have to make recourse to CT or MRI visualization. This is the so-called hook test, and the hamate hook is a fulcrum around which the flexor tendons are stretched. So if you acutely flex the fingers against resistance, put the hand into ulnar deviation, then and put traction on those fingers, then you'll get pain over the hook of the hamate. So that's the hook test. Resisted flexion of the fingers with the wrist in ulnar deviation, and you'll get impaction against the hook of the hamate, causing pain. Now you can see the hook of the hamate is hidden away and superimposed on the other bone. So this is the main hamate, and the hook is projected and coming out towards us on an AP X-ray. You may have to do a carpal tunnel view or do an angulated semi-supinated view on an X-ray to identify that, and even then it may be difficult. And so we'll make recourse then to CT scanning to identify hamate hook fractures. We'll try non-operative intervention, but it's very hard to provide a splint that's going to immobilize that. And we end up, it's impossible to get that to be fixated with a screw. So we end up simply excising that hook of the hamate. This is the whole hamate bone, and this is the hook. And you can see the flexor tendons have a fulcrum around that hamate when you flex the wrist. And this just shows then the excision of the hook of the hamate. We're going to come now to some closed tendon injuries. And we're going to start with central slip, the boutonniere deformity, as well as the other closed tendon injuries. And there's a forceful flexion of the finger, for example, an impact with a ball. And so then the central slip will get disrupted. And what happens is the lateral bands then subluxate, and then you have that finger drawn into flexion at the PIP joint and hyperextension at the DIP joint. Now, this boutonniere problem, this boutonniere deformity, which can be very hard to fix later, takes time to develop. So we need an early diagnosis, and often the early diagnosis is problematic because the finger is painful and it's impossible to move it and it's swollen. And so then we have some tricks in making the diagnosis. So this is the established boutonniere deformity. You can see it takes time to get this sway back deformity developing due to the stretch of the tendons. And so initially, the PIP joint looks normal because all that's happened is we have a disruption of a central slip, but the lateral bands still stay where they are, and it takes time for them to migrate volar to the PIP flexion and then to develop the full-blown boutonniere deformity. It may take some weeks. So there's a test called the Elson test, whereby if you flex the PIP joint and then you ask the person to extend the DIP joint, they should not be able to do that. And so if I've got my PIP joint fully flexed, and if you do that yourself, and then try and extend the DIP joint, it's awfully hard to do that. It's almost impossible to extend the DIP joint. You can do that on yourself. There's the so-called modified Elson test where you put the two fingers together and then you brace them against each other and try and extend the DIP joints, and you cannot. And only when there's a disruption of the central slip mechanism and everything pulls backwards, that you'll then be able to do that. So this is the normal side where you can't extend the DIP joint, and this is the abnormal side because the whole mechanism, because the central slip is disrupted, pulls back. And so this is the flexed position. This is trying to extend. Now I can extend. So this is the abnormal side. I can't extend the DIP joint on the normal side. That's called the Elson test. This takes you then through step by step, and you try and extend the DIP joint. And when it's abnormal and you've got a disruption of the central slip, you can extend the DIP joint. The central slip is still intact. We've got redundancy of the lateral bands, and so you cannot extend the DIP joint. So this is a patient of mine who had a jamming injury, swollen at the PIP joint, but a perfectly straight finger. Elson test, so the central slip is disrupted. And so that's the abnormal side. Splint them in extension. PIP is splint in extension. You keep it splinted for 6 weeks, leave the DIP joint free to move, and then they're going to do well. And so that's important. So you splint for 6 weeks. It's absolute. You allow the DIP joint free motion, and then you transition maybe to nighttime splinting at 6 weeks. You can also do a so-called relative motion splint, which is this, which keeps the injured finger at a position inferior to the adjacent fingers, and that will also relax the central slip. So you can either do extension splinting of the PIP joint or do a relative motion splint. But that splinting has to be absolute for 6 weeks to allow repair of the central slip to occur. And there we have it. And if you fail to treat it appropriately, then you're going to get the boutonniere deformity. But as I said, the boutonniere deformity takes some time to develop. So again, returning to sport, if they've got a protective splint, and you can make these protective splints pretty solid, you can make them out of solid material, they can go back to sport right away, depending on the type of sport they play and the position they play, and also the rules and regulations of that particular sport. Many of these are neglected, and this is an interesting quote. One only has to look at the hands of retired professional football player to see that few bother to have their boutonniere deformity reconstructed during their play days, and their fingers are just then a total mess when they're in their retirement years. So that's an interesting quote. So what about the jersey finger? This is also a closed disruption of a tendon, but the flexor tendon. And it's when you're grabbing onto the jersey, so it occurs in football or rugby, for example, and the person you're trying to tackle runs away from you and you're still grabbing the jersey, and the flexor tendon gets avulsed. And so the FDP is avulsed. It's called the rugby jersey finger. It's reportedly the most common in the ring finger, and that's apparently because the attachment of the FDP in the ring finger is its weakest, and also that's the one that you're generally grabbing with, is either the ring or the middle finger. So again, the initial examination can be a little bit disconcerting. The finger's swollen. They can't move because it hurts and it's difficult to diagnose. And the pathognomonic sign is the inability to flex the DIP joint, and the normal cascade of the fingers will be lost. We'll do x-rays, but if the tendon has avulsed cleanly off the bone, it's not going to be helpful. But if the tendon has pulled off a fragment of bone, then you'll be able to see where the end of that tendon is, and that will be a clue. An MRI and ultrasound may be helpful. Here's a patient of mine who had a FDP rupture, can't flex the DIP joint. And if you're a pitcher or playing ball sports, you really need to tuck that finger in and to grasp around a ball. Here's the piece of bone. You can see it's retracted all the way down there. So that's a clue that that person had a FDP tendon avulsion. And one needs to repair these in quick order, and it's usually anchored with the bone anchor back in place, because what will happen is that will retract, and then you won't be able to pull it back out to length. Now it's a decision to make. Dependent on the type of sport. A football player in a certain position may say, gee, heck, I'm not going to get this fixed and go through weeks and weeks of rehabilitation. I'm just going to accept the fact that my DIP joint isn't going to flex, and that's okay with me. In other sports, it may not be okay. So it's not an absolute to operate. However, if one's going to do surgery, it needs to be done relatively quickly. Post-operative management is fairly complex because you have to allow tendons to glide. It takes several weeks of cautious, active, and passive motion before we can allow them to go back to full activities. And dependent on the sport, there's no real clear-cut guidelines as to when this repair is strong enough to return to that particular sport. What about a mallet finger? That's from a jamming injury at the fingertip, and the extensor tendon gets disrupted. There may be a fragment of bone disrupted, or it may be a clean disruption of the tendon from the bone. And there's a droop at the terminal phalanx. So instead of the central slip going, as we showed with the boutonniere, it's a mallet. It's at the tip of the finger, at the DIP joint. And so there's a dropped finger there. And that's awfully clumsy. It just gets in the way. And again, the essence is continuous splinting to allow that to reattach. And clearly, non-operative intervention are far more successful than operative interventions. Again, the examination may be difficult initially and masked by pain and swelling. You definitely want to do x-rays to see if there's an associated little fracture fragment. And even if there's a fracture fragment, the majority of those patients are still treated by splinting. There's a variety of different splints. This is a very elegant little splint that the therapist can make out of plastic for you, and it's held on simply by Velcro. You can make them out of aluminum foam, for example. And again, it needs to be absolute and continuous for a 6 to 8 week period. And then with time, you gradually start progressive motion. Now, if there's a fracture fragment, so long as this joint isn't dislocated, then we're going to treat them exactly the same way. Just because there's a broken bone, it's still a tendon injury, a tendon avulsion. The joint is congruous, so we're going to treat them just with a splint as we did with a pure tendon injury. There's your splint. This is another type of splint that you could use. And if you want absolute fixation and you want them to return to sport earlier, you can make it as robust as you like. and give them protection. Occasionally, if there's a big dislocation and a big fracture fragment, then we'll do pinning and fixation in that manner. I like to use kinesiotaping as a step down from the bracing because this still provides protection, and the kinesiotaping also allows flexion. So it's sort of a cross your heart type of placement. And after the 6 weeks of absolute immobilization, then I'll use this kinesiotaping. I've had a collegiate rugby player play the entire season in the scrum with a little mallet splint and got a perfect result. So you can get back to sports, and it depends again on the type of position and the type of splinting that you provide the patient. And to talk a little bit about pulley ruptures. These are most common in rock climbers. So the pulleys hold the tendons up against the bone, and if without those pulleys you don't have the excursion, and so you can't flex the finger, particularly if the A2 and the A4 pulleys are disrupted. Those are the most important. And the rock climbers, in fact, will wear protective ring splints around their fingers to stop disruption of the pulleys from occurring. They generate extreme force when they've got a clenched fist and they're clambering up the sides of a rock face. And sometimes we may have to resort to MRI scanning and special imaging to show the fact that the pulley is disrupted and the tendon has migrated away from the finger. What happens with time is that they then lose the capacity to flex the finger. So that needs to be treated. And very often we need special imaging to make that diagnosis. Most we can treat with an external pulley ring, and I'm going to show you that in a minute. If there is a total high-grade disruption of both the A2 and the A4 pulleys, they are going to need operative intervention. There's an array of different imaging processes, and there's also been a classification as to how much displacement you've got of the tendon away from the bone, and if there's a greater amount of displacement, and certainly if you've got multiple pulleys, you're going to need surgical repair. However, most can be treated either with a soft ring or a hard ring. The higher the degree of disruption, the more rigid you're going to need an external ring to provide you that support. As I've said, some of the rock climbers will just wear these preventatively to give them that extra support that they need. If there's a high-grade disruption, we actually need to repair those pulleys, and then there's a fairly involved recovery period. Sagittal band ruptures, these are interesting because the extensor tendon is held in place centrally by the so-called sagittal bands of the extensor mechanism. And if you just go to so if you flick your finger against resistance like that, you're going to potentially disrupt that sagittal band, and the extensor tendon will fall off to the side, and you'll lose the capacity to be able to actively extend that finger. And so here we have the sagittal bands. They hold the main extensor tendon centrally, and if that sagittal band gets torn by a closed disruption, then the extensor tendon is going to slip off to the side, and you won't be able to extend the finger. MRI imaging may be useful, but mostly it's a clinical diagnosis. A lot you can treat non-operatively by a so-called relative motion splint, so we're just relaxing that affected finger. But if they don't respond within a 6-week period, then we'll do operative repair. And generally this repair is very successful. It's a matter of just repairing it, sometimes using a piece of tendon as an internal brace to reinforce it. But no matter what type of repair is done, and many are advocated, they are all very successful at treating this problem. We're going to come more proximally to a disruption of the extensor carpi ulnaris. So the extensor carpi ulnaris is on the side of the wrist, dorso-ulnar, and it can tear from its moorings as it travels through the tunnel, particularly in baseball, a pitcher or a batter. When they take a swing, a forceful swing, they can tear that loose. And it can become pretty disabling. So here's the extensor carpi ulnaris, and it will disrupt out of its pulley system just right at the wrist, particularly when someone forcefully twists the wrist in ulnar deviation. And you can see the tendon gets disrupted out of the confines of its housing, and then you lose your capacity for wrist extension, and also it becomes quite painful because this tendon is just twanging around the edge of the ulna. And here you can see an MRI. You don't always require an MRI to make the diagnosis. You can see all the inflammation. And then if it's early with low grade, we can treat it by non-operatively, but a lot of them come as a result of fairly forceful disruption and require operative intervention. So this is a patient of mine. The ECU is subluxated, so now it's bowstringing on the volar side of the ulna, and it should be sitting on the dorsum of the ulna. And here you can see the inflammation, that same patient, and the tendon is subluxating in a volar direction. And we use local tissues of the extensor retinaculum to shore that up and repair it. And then post-operatively, you have to control pronation and supination of the forearm. So they often go in an above elbow Munster type of splint to prevent them from going into ulnar deviation. So you want to avoid that, and you want to avoid rotation and supination. So they may have to have an above elbow thermoplastic splint. If it happens in a baseball player, and these are probably the most common sports in which it will occur, it takes quite a lot of progressive strengthening. So they'll start with light swinging of the bat, cage batting, tee batting, and finally get up to full strength. And it may be as much as 3 months before they back up to full capacity. Surgery, as we've already alluded to, involves reconstructing the retinaculum to confine the ECU in place. And then we've said protected return to play may take as much as 3 months or more. A little bit on tenosynovitis, and then we're almost done. De Quervain's tenosynovitis is repetitive use, the first dorsal compartment. And so there are two that are very close to each other. There's intersection syndrome, where you have the tendons of the first dorsal compartment crossing over the extensors of the wrist. And so you get a rubbing there. Classically, that occurs in competitive rowers, the intersection syndrome. In other words, if you mimic that sport of the rowing action, the curl and the pull, the curl and the pull, you'll have then pain here about 5 or 6 centimeters proximal to the wrist and a little bit dorsal to the first dorsal compartment, where you get De Quervain's stenosing tenosynovitis. So again, these are the 2 points, intersection and De Quervain's. And the third one we're going to talk about in a minute is repetitive extensor tendon stress and tendinitis that we'll see over there. So going back to De Quervain's, you know you can diagnose it by the so-called Finkelstein or Eickhoff tests, where you stretch the extensor tendon of the first dorsal compartment into ulnar deviation. And again, here's the first dorsal compartment, here's the intersection area. And this is the Finkelstein test, where you grab the thumb, and the Eickhoff is similar, where you actually forcefully, passively deviate the wrist in ulnar deviation. The most sensitive and predictive test is the so-called radial synergy test. And what you do is you have the patient abduct the little finger. That automatically fires the thumb extensors, and they'll have pain right where my cursor is. And that is the test that has the greatest sensitivity and specificity, because if you've got arthritis at the base of the thumb and a variety of other inflammatory conditions, these two tests, the Finkelstein and Eickhoff tests, are going to be positive. So this is the one that is the most specific and also has the highest degree of concordance of specificity and sensitivity, the radial synergy test. Most are treated non-operatively by anti-inflammatory medications, avoidance of the thumb up position, local steroid injections, usually by 2 times. If they haven't gotten better, then we recommend a surgical release. Without question, the combination of splinting and injection is the most effective. You seldom need an MRI to make the diagnosis, but this happens to be an MRI, and you can see the inflammation here around the tendons of the first dorsal compartment, the extensor pollicis brevis and the abductor pollicis longus tendons, the 2 tendons there. The way to immobilize is a full thumb spiker. You can leave the IP joint free. The carpal tunnel brace is going to be ineffective because it doesn't stabilize the base of the thumb. So don't use that kind of brace. At least 70% will respond to non-operative interventions. Intersection syndrome is just a little different in location. The treatment is the same: local steroid injection, avoidance methods, and also splint immobilization. Finally, we get to, excuse me, extensor tendon exertional tenosynovitis. And all the tendons are retained by the extensor retinaculum. And again, I'm going to use my hand. So there's an internal brace wristlet that goes around the dorsum of the wrist. And the first dorsal compartment we've already talked about at the base of the thumb. And then as we go across the dorsum of the wrist, the 4th dorsal compartment, all the extensor tendons to the fingers travel through there. And by repetitive action, you can get a so-called repetitive stress synovial proliferation. And you can see the synovitis that you get there, and you get that so-called tuck sign when you extend the wrist and extend the fingers simultaneously. Here you can see the swelling. You can see almost the surface anatomy, the outline of the extensor retinaculum, which is just proximal to that. Again, treatment is by local steroid injection, avoidance mechanisms. But if we have to do a surgery, we'll actually do a synovectomy and take away a strip of that extensor retinaculum, about 1 centimeter or so, just to give those tendons more room. And then here you can see this is an MRI of a patient with extensor tenosynovitis of the 4th dorsal compartment, and an ultrasound likewise showing the inflammation around the tendons of the extensor tendons of the fingers, the 4th dorsal compartment. Immobilization we've talked about, the non-operative treatment, and the surgical treatment. So we've done with part 2, and thank you very much for your attention. We've covered probably some of the more common athletic injuries and sports injuries compared with the first talk. But I'm going to have questions, but I'm going to take you through a case. And just as a recap, excuse me, a 17-year-old high school basketball player destined for scholarship sustained a jamming injury from a ball when it was sent to him in rapid fire to his dominant index finger. He has pain and swelling at the PIP joint. Radiographs are normal, and you suspect the possibility of a central slip insertional injury. This is that finger that I showed you. It's perfectly straight, but it's pretty swollen in this area and it's painful. So how do we make the diagnosis acutely of the potentially a central slip deformity that may become, a central slip injury that may become a boutonniere deformity? So what's our clinical evaluation? We'll do an Elson test, and you can see this is the abnormal position. You can extend the DIP joint in the abnormal situation. You can't extend the DIP joint in the normal finger when the PIP is hyperflexed. It takes time to evolve into a boutonniere deformity, so we want to get ahead of the game. This is the mechanism of injury. We don't want it to go on to a full-blown boutonniere deformity. So the treatment of the acute injury is immobilization of the PIP joint, either by a solid splint or by an aluminum foam splint, or by a relative motion splint. And for how long? We said for at least 6 weeks, and then you can continue protection with one of those figure-of-8 splints when they return to play, either with a solid splint or with one of these figure-of-8 splints when they return back to play. So with that, thank you very much, and I hope I've answered the question on the PIP joint relocation of the dislocation, but I'm open to any questions at all. So thank you. We're just right on time.
If you found this content valuable to you, please consider joining SMA by visiting sma.org/membership or making a tax-deductible donation. Visit sma.org/give to support our mission. Thank you.